Hey, I just want to first thank everybody from on behalf of the AdMeTech team. Our relationship with the North Shore and NAACP is very important. We've been very appreciative over the years for that support and having these types of events and sessions. They've made an impact over the years, so I just want to make that note. I'll turn it over to Dr. Wason now. For his presentation.
So tonight I want to go over, how I sort of manage patients that come to me with an elevated PSA, and then touch on some of the advanced diagnostics that we use in the office to screen men for prostate cancer and to diagnose them, and what are some of the treatment options. I have no disclosures for this talk tonight, other than we all know somebody that's been affected by prostate cancer. This is my grandfather, James Edward. We call him Ernest. He grew up in Barbados, and that's our second home. And he died of metastatic prostate cancer, and he was diagnosed during a time where there really wasn't much screening done for prostate cancer, and treatment options were limited. In the goals of today, I just wanted to go over who we screen, when we screen, how do we make the diagnosis, and then touch on some of the imaging and the biomarkers that we use to make the diagnosis of prostate cancer. This is a typical gentleman that I may see in my practice, Mr. Smith. He's late 50s. And he's interested in prostate cancer screening. His grandfather also died of metastatic prostate cancer. He had a brother a little bit older, recently diagnosed with localized prostate cancer. He's really asymptomatic, has no voiding symptoms. He feels well. He works out frequently. Hyperlipidemia. He's on a beta blocker and a statin for those. He's married. His erections are normal. He wants to keep it that way. First and foremost, I really, like to perform a digital rectal exam. I think you can miss a prostate cancer if you don't do a physical exam. He has a slightly enlarged prostate. It's smooth, it's rounded, there's no nodules. I trained at went to medical school at Howard University, and LaSalle Lafall, he was the first Black president of the American College of Surgeons. And you just remember him being on rounds, and he said, really, the only reason not to do a rectal exam is if you don't have a finger. And, it was just very powerful listening to him. And just in the back of my mind, when I'm with patients, I think of Dr. Lafall, who died a few years ago. So, make sure that as a patient that you're getting that physical exam. I think a lot of primary care doctors nowadays, and I certainly have picked up some high-grade cancers just on the digital rectal exam alone, because there's some high-grade cancers that don't secrete a lot of PSA that you may miss if you're just looking at the PSA alone. His PSA is 4.5, so this is elevated. If you're in between the ages of 50 and 59, really the PSA should be under about 2.5 to be considered normal. And so, we always repeat the PSA. What is PSA? PSA, it's only secreted by the prostate-specific antigen. Where is the prostate? It's tucked in between the bladder and the rectum. It's usually a walnut size, but can grow to the size of a grapefruit. Just because you have a big prostate doesn't necessarily mean that you have prostate cancer, but there's a variety of sizes of prostate. And I would say that the larger the prostate is, the more it does secrete PSA. And so I'm actually less concerned if a man comes in with an elevated PSA and they also have a large prostate to match, and very small prostate. That means the PSA density is very high, and that's really concerning to me. It's part of the urethral channel. As men age, it does compress the urethra, and it can cause difficulties urinating. This can be urgency, frequency, weak stream, waking up at night. And so, men, may have lower urinary tract symptoms secondary to a large prostate. I would say most men, if they don't have any prostate issues, really don't have much in the way of urinary symptoms. Prostate's a reproductive organ, contributes to semen, and it just, it gets us in trouble. 1 in 8 men will be diagnosed with prostate cancer and in his lifetime. And really, I think the key takeaway is if you diagnose prostate cancer early, you can be cured of prostate cancer if it's localized. If it comes outside of the prostate, that's a different story. Those patients really are never cured. We can manage them very well, but really never cured. So let's diagnose prostate cancer at an early stage where we can do something about. And the goal nowadays is to maximize detection of what we call intermediate and high-grade cancers. There's a wide spectrum of disease. There's low, intermediate, high-grade prostate cancers. We really want to ignore the low-grade prostate cancers because those are not really a threat to health, but they do go into all the patients that are diagnosed with prostate cancer. So if you're fortunate to be diagnosed with low-grade prostate cancer, most likely you won't need treatment, at least in the short term. So our goal is to minimize detection of non-life-threatening cancers, for which there are some, and then really decrease the unneeded biopsies and treatment of men who may not have the benefit of prostate cancer treatment. Everything that we sort of do as urologists comes from the American Urologic Association. A lot of their guidelines are evidence-based, and they came out with this guideline a few years ago about what do you do? How do you sort of detect prostate cancer early? And what is early detection? Just means screening, and it just means we want to detect disease at an early stage. Patients are pre-symptomatic or asymptomatic when really, a man would not have any other reason to seek care. If you're under the age of 40, you don't have to worry. You don't need a PSA. If you're over the age of probably about 75, 80, you probably don't need your first PSA. You need at least a 10-year life expectancy. So if you have, a family member that's has a lot of medical comorbidities, cardiovascular problems, et cetera, and may not have a very long life expectancy, you probably don't need to screen that particular patient for prostate cancer. The key age group, I would say, is 55 to 69. When do you get the first PSA? I think that it's reasonable, to get one if you have, strong family history, to get one earlier rather than later. I think probably getting your first PSA at the age of 40 is reasonable. If it's very low, you can push it back to, even about 5 years. How do we find prostate cancer? PSA, digital rectal exam, best used in combination. We consider annual screening as sort of an easy way to screen men. It doesn't necessarily mean you have prostate cancer if the PSA is up, so you really need a prostate biopsy. Prostate-specific antigen is only secreted by men who have intact prostates, so that's a good thing. It's only made by the prostate. So if the PSA is up, that means that there is some sort of prostate disease. It could be benign, non-cancerous, or malignant cancerous. That's how we sort of figure out if there's something going on. It can be elevated for a variety of reasons. So recent ejaculation, bike riding, sexual intercourse, urinary tract infection. So a lot of things can cause the PSA to be up transiently. It should not continue to rise. So really what you want to know, what is my PSA? What's my trend? Sometimes what is my free PSA? These are sort of a deeper dive into the regular PSA. PSA is considered a biomarker, so it's used in pretty much all phases of prostate cancer screening to make the diagnosis after local treatment. So if you have a radical prostatectomy, if you've had your prostate removed, your PSA should be undetectable, shouldn't have any PSA. If the PSA starts to rise, which it can in the future, even after treatment for prostate cancer, then that's obviously a bad sign that there may be disease coming back that you really need to look for. And it's a really good marker to follow men and how they're doing, how they're responding to treatment. Mass screenings we used to do, we really don't do it anymore. It used to be on a Saturday, you'd go into a church and everyone would get a PSA. Now you really need to have a nice conversation with either your urologist or primary care docs about what is the value of prostate cancer screening based on my age, my overall health. Do I have a strong family history? And so a lot of things go into whether or not you should get screened or not, because it can cause a downstream cascade of events, an uncomfortable biopsy. And so we really want to not go down that path, unless someone has a clear understanding of what prostate cancer screening is. I've had, a few situations where just someone was not mentally competent, and the effects of treatment, we can't, discuss with a patient how a treatment is going to affect him. So I would say shared decision making is great. Usually, who gets screened is often dictated by the primary care providers, and who gets biopsied is often dictated by the urologist. If your PSA is very low, you can push out screening 2 to 4 years. If you're in that sort of gray zone 1 to 3, you may want to, make sure that you check your PSA every year. If it's over 3, if you have a suspicious digital rectal exam, then we'll repeat the PSA. We may do some adjunct PSA testing, like a free PSA, and we may use biomarkers. And in this particular phase, I'll talk with you about one of them that we use in sort of the pre-biopsy phase. But these are patients that we're concerned about. We'll offer usually a multiparametric MRI. So when someone comes into my practice, they have an elevated PSA. What I can do is take a little ultrasound probe, put it on their lower abdomen, and I get this nice picture here, which shows us the bladder and the prostate size. So we know pretty much instantly how big the prostate is. Am I worried? Am I not so worried about this particular gentleman? This is an ultrasound in the lower abdomen. So very, very, very well tolerated, it's very comfortable, and it gives us really actionable information right away. Biomarkers, or, what are really sort of blood and urine tissue that we get a lot of information about. We can use them in the pre-biopsy phase, after treatment, post-treatment. Biomarkers really shouldn't be used in all patients. I like this one in particular called Select MDX. So if someone's a little concerned, let's say the PSA is slightly elevated, they're in that gray zone. This is a urine-based biomarker. So I need to do a digital rectal exam, and we incorporate things like the age, the PSA, the prostate size, and the urine is sent off, and it looks for mRNA from really 2 sort of areas, which you can see there. And this will show us is what is the risk of someone's risk of clinically significant prostate cancer. So this is a really nice test for someone who may be on the fence, that is unsure about proceeding with the biopsy, that may have a large prostate and a borderline PSA. So this will help me decide whether or not that particular gentleman should get a biopsy. So if it's very low risk or even low risk, multiparametric MRI, really, this is becoming the evolving gold standard. So if someone comes in, I'm worried about them with the PSA, I will get a multiparametric MRI. Usually has to be with a 3 Tesla magnet. There are a few centers around here that don't use the 3 Tesla magnet, and I would say that just be cautious, because some of the data that you get from not a very high fidelity, MRI, can be a little bit, askew. So just keep that in mind. So we use a 3 Tesla magnet to figure out, are there any lesions within the prostate that I'm concerned about? Is there any disease that looks like it's coming out of the prostate? Are the lymph nodes involved? Are the bones involved? So it gives us the size, a lot of information. And I usually get this on somebody who has an elevated PSA up front, or do we want to do a fusion guided biopsy? So, really ask your urologist, what does my MRI show? And really the radiologist is giving us one of these lesions, 1, 2, 3, 4, 5. If you have a 4 or a 5 noted, those are usually areas that are clinically significant prostate cancer. So we typically will biopsy any lesion that's a 4 or a 5. The 3s we don't typically biopsy, but you can get a lot of information from the PI-RADS score. And I would say you really need a dedicated radiologist who's reading this frequently to really trust the diagnosis. Other options other than MRI, which may be, sometimes a little expensive, is micro ultrasound. And one of our, where I used to work in at Urology of Virginia, we were one of the kind of the early sites for using micro ultrasound. And this gives us a phenomenal high resolution ultrasound picture. And some centers are using micro ultrasound where you can almost monitor lesions in real time. There's a scoring system very similar to the PIRADS scoring system. And so some centers have adopted using this instead of getting an MRI every year. How do we do a prostate biopsy? Typically, we'll take 12 samples, 6 on either side. It's done in the office with a local anesthetic. It's very quick, less than 10 minutes. We were doing this today in our office, and I work with an ultrasound tech who's done about 30,000 of these biopsies. And, it's just very quick. We try to get, guys in and out and off the table in less than 10 minutes. And so the biopsy is really important to tell us, do you have prostate cancer or not? And then what is the Gleason grade? How aggressive is it? How much of the sliver of tissue is actually involved? And we actually get a percentage. Where's the location in regards to the prostate? Because these are mapped out. Is there any perineural invasion or other types of cancer within the prostate? So it gives us a lot of information, and we usually do sort of 6 samples in the peripheral zone, the side aspect of the prostate. There are other ways to do a prostate biopsy that's not through the rectum, which is sort of the standard transrectal approach. So urologists may recommend a transperineal biopsy. This is done through the perineal area. Theoretically, there's potentially less risk of infection, although there was a really nice randomized controlled trial looking at the two, and there really wasn't, surprisingly, a huge difference in terms of infectious complications. And so I think either one is very acceptable. In some situations, you may want to take the MRI and fuse it in real time with an ultrasound. And this is also standard of care. So if you have a couple different lesions in a large prostate and you want to be sure to target it, you take the MRI, you fuse it to the ultrasound, and the urologist in real time can target that particular lesion, and just to make sure that you've actually targeted that lesion under ultrasound. This is just a picture of what the MRI targeted biopsy looks like. There's quite a few systems out there that do this now, but it's a really nice way to make sure that you target lesions that are found to be abnormal on the MRI. And then the pathologist will give us what we call the Gleason score or the grade grouping. And we've made it a little simpler. Now, 6 is a 1 and 7 is a 2, etc. And then based on the rectal exam, your PSA, the Gleason score, how many pores are involved, we will put you in a risk category, which can go from very low, low, intermediate, high, and very high risk prostate cancer. And that will direct whether or not you need any additional imaging, such as a bone scan or a CT scan. This is another biomarker that can be used. So if you have a very small sliver of a low-grade prostate cancer and you want to know the biologic aggressiveness, you can actually send a sliver of the prostate cancer to this company, and they will look at the biologic risk of your prostate cancer. Am I a candidate for active surveillance? And I think that in some situations, this is pretty helpful, especially if you're, on the fence between surveilling someone with low-grade prostate cancer or active treatment. Although I would say that PSMA has been sort of emerging as the gold standard. If you really want to find prostate cancer outside and you're really concerned about high-grade disease, metastatic disease, this is the way to go. There's a radionucleotide that's tagged to PSMA. And so if there's circulating cancer cells outside of the prostate, this is given an IV injection, this area will light up on a CT imaging. So we're using a lot more PSMA in mainly the patients that have or we suspect to have a higher grade disease. And nowadays there are some therapeutics where, if the lesion lights up, you can give them sort of a targeted agent to destroy these cancer cells outside of the prostate. So, if you're diagnosed with prostate cancer, how can you be proactive? Stop smoking, consider a low dose statin, vitamin D, metformin. And this is Dr. Klotz from the University of Toronto, where, I grew up and I kind of went to, undergrad. One of the sort of the grandfathers in terms of, prostate cancer, treatment and active surveillance. And so this was, his recommendations at one of our recent meetings. So I would say that prostate cancer is common. Aggressiveness is quite variable. And we really want to maximize detection of intermediate and high-grade cancers. And we use a combination of imaging, genomics to improve risk stratification and deciding who really needs treatment and who doesn't. So thank you for your attention, and happy to take any questions now or later on in the program.
Thank you so much, Dr. Wasson. Anybody has a question?
I'm curious. Thank you very much, Dr. Wasson. Really helpful. I'm curious what you see for men's willingness or resistance to screening. Is there something about it that, other than the sort of physical intrusion, how do we think about that? And I'm curious if your breadth of experience, what about that is there, and are there things we should be thinking about? Because I assume the purpose of this is to spread the news of this and make it more normalized that people would pursue screening earlier. So is there something we should know about it or be prepared for that would make us more effective ambassadors?
Yeah, I was, fantastic question, Andrew. I too was like you. I would say, I turned 45 last year. I had a family history of prostate cancer. I probably put off, screening partly because of fear. What if your PSA is up, and what does that mean for me? What I would say to guys that are scared is that it's very normal, and I think you want to maximize your chance of staying here. And I would say that the earlier the better. But it's just amazing to see especially when you look at colon cancers, rates of colon cancer in young men and women are just astronomical, and people are dying in their 40s. And so I'm very happy that they've actually moved the screening guidelines to make colonoscopies earlier at the age of 45. A good friend of mine just came into the operating room and said, "Hey, I'm 45, just got my first screening, and I have T3 colon cancer." So there's something out there where I think the rates of malignancies are going up. We are all living longer, and so we're all going to eventually suffer some sort of issue. I would say that really, the digital rectal exam can be uncomfortable. I really try to make it as as sort of quick and sort of painless as possible. We are using sort of the ultrasound to help guide us to be a little bit more sensitive on who may need this invasive test. And we know that biopsies carry risk, bleeding, infection. And I did a biopsy last week. The guy did great for 4 days, but he ended up in the hospital. And so I think that the biopsy is not without some risk. But I think that the risk is relatively acceptable. There's very few patients that have a significant amount of problems. And, I just think of John, who has, a wealth of experience, and, he's there getting, guys to laugh, while they're actually getting biopsies. So we have a lot of things to sort of, get you over the hump.
But you're awake during this whole procedure. I imagine that's a significant concern people have.
Yeah. Yeah, I think it's there's just so many guys out there, and it's not practical to put everybody completely asleep in some situations. But certainly if someone is very, very anxious, we can give them a Valium. We use nitrous oxide in our office sometimes. So there are some adjuncts for select patients that we will do.
I'll take all the things you got, Doc, whatever it is, man.
The trifecta.
Thank you. A question, Dr. Weston. So for the biopsy that you're talking about, is that through cystoscopy for both kinds that you just spoke about?
So there, I would say that the standard is we take a sort of an ultrasound camera and is put through the rectum. So digital rectal exam, we do, do a nerve block immediately, and really that eases the discomfort. So that's the first route, the transrectal. And then there's another route where you can go through the perineal area, sort of the skin in between the anus and the base of the scrotum. So you can actually go through the wall of the perineal area and target the prostate as well. So those are two areas. You still need the transrectal ultrasound when you're doing a perineal biopsy, just to help guide the needle. But because we don't want you moving around too much, most of the time that's done under sort of sedation or anesthesia.
Thank you.
Mhm.
Hi, Dr. Watson. Arnie Cowan here. Back in the day, we used to get our annual digital examination, and now my doctor just does the PSA. And I'm not sure. I might have missed this if you addressed this already. But would you say that just looking at the PSA numbers is adequate in terms of prevention and being able to detect any issues?
I would say no. I would say, the PSA by itself is better than not doing the PSA, I would say, but really it's done best in combination. And I have probably a handful of guys where I felt the prostate rock hard and the PSA has been low. And in high-grade prostate cancers that affect some family members, some patients, the prostate cancer won't secrete a whole lot of PSA. So if you were just looking at the PSA alone, albeit they're very rare, and in a population, you could probably get away with it, but you are your own best advocate. And I think that docs have sort of moved away from the physical exam, which is a little unfortunate. That I think that there's just nothing like laying your hands on a patient and kind of looking under the hood. It doesn't add that much to the to the visit, but I would say that the PSA is better than nothing. But if you're there, say, hey doc, what does my prostate feel like? I'm sure they wouldn't say no.
Yeah, well, I get the sense that she is hesitant. She tries to avoid doing it, like looking at the PSA and recommending colonoscopy, and it's not the same as kind of the old time doctors that were really used to it. So you think I should kind of insist on it?
I would do that, and not just for examining the prostate, but you can feel rectal cancers as well. Just by doing the prostate biopsy, and I looked and I see, okay, well, there's blood there, or it's just slightly abnormal, and so you can pick up things from a physical exam. But yeah, I guess it's old school. My wife says I'm old school because I like to make phone calls. She's like, oh, that's just text, but
you and me both. Yeah. Thank you.
I have a question, a story, and then a question, and this goes to what you were saying about the digital rectal exam. My mother had rectal cancer that was not discovered because they didn't do a rectal exam on her. She had a tumor that grew on the outside of her rectum, so she had colonoscopies that were completely clean. She had no symptoms. It wasn't until the tumor grew into her tailbone and she started having pain from that. And her GP told us that he was devastated. He didn't do it. And he does it now. He said after that he is an evangelist for rectal exams, not just for prostate. As you said, it can discover other things. And she, no symptoms. But my question is how, and I might have missed this in your presentation, but how strong is the kind of correlation if, like, my husband's father had prostate cancer? He didn't die from it, but he had it. They often say you you die with prostate cancer, not from prostate cancer. But how much does that elevate his risk, and how much should I nag him to nag his doctor to give him not just the PSA?
Those are the highest risk. I would say probably 2 to 4%, depending on which study you're looking at. But it does elevate your risk. And so certainly I would also look at when, his dad was diagnosed with prostate cancer.
It was later, yeah.
Was it later? So it may just be a sporadic prostate cancer, but I would say that now we're doing a lot more genetic oncology. So anyone that's diagnosed with high-grade prostate cancer, they really see a genetic oncologist, and they're tested for, a whole host of genetic mutations, because you want to know, are you carrying a BRCA1 mutation, BRCA2? Right. There's a variety of other ones that are associated with colon cancer that are, put you at higher risk of developing prostate cancer. And that's the information you want to know for your, offspring. Are you carrying one of these moving forward? But certainly he seems to be at, higher risk of prostate cancer. So,
permission to nag is granted?
Absolutely.
I have a question, Dr. Wiesman. So first of all, I'm such a believer in prevention. I have the pleasure of working with many physicians on the business side of medicine, and for myself, my family, and, related to my career. And, it was a great talk. I thank you for it. And I don't know if there's other presentations tonight, and I'm stealing anyone's thunder. But I'm wondering, given that we're the NAACP, and given that we have a health committee that's and sponsoring this talk tonight, with all the concerns that out there that men have, are there special challenges with men of color that as a branch and as a health committee that we should be aware of? It is, what kind of guidance would you give us in that area?
Yeah, I would say that, we're still trying to, figure out sort of like, the genetics of it, and, are, Black men of, color, increased risk of a higher grade prostate cancer, what's considered taboo. I think that, we should just advocate, I think, for all men to kind of, get screened, because, at least in our practice, when I was at Boston Medical Center, we just had a lot of young guys of color that came in with a very high, grade aggressive prostate cancer that was outside of the prostate. And so, I do think that there's, some element of increased risk, and, we have to sort of really kind of focus in on sort of the young men of color,
I think I was also, in my mind, I was thinking a lot about the general rightful mistrust of the healthcare system, and about access, and some of the other sort of social determinants, and that we're all so well familiar now that work in healthcare. I was thinking some about those factors, as well as, is there sort of genetically or, medically some sort of increased risk?
Yeah, I would say that, I would just sort of, advocate for, brothers and uncles and family members to, to get screened. I think that, the digital rectal exam can be uncomfortable. There's a lot of young guys that, maybe, associate that with homosexuality. And so, I think that, I think we have to kind of, push forward with, all the reasons to get screened. You have, young kids, young, spouse, and, it's your health.
Dan, you had a question?
Yes, thanks. Doctor, thank you for your time. Thank you for being with us, and thank you for your work. I feel like you've told us a lot about the kind of public health awareness and what people should be thinking about side. I'm curious if there's anything that goes with that from your perspective, from a like advocacy and policy side, just like as citizens in our communities, locally or at the state level. Are there any policies or any advocacy areas that, if you had your magic wand to do something for public health in this area, that that you would be looking for change to be made?
Great question, and I'll probably turn it over to Thomas and Dr. Stern, because they are very strong advocates, and every couple of months they are having a lot of the organizations and sort of the states senators to really push legislation and money forward for pretty much anyone who comes with them that wants a second opinion to get evaluated, because a lot of it comes down to to access and having that sort of VIP care. How do we make that available to everybody that wants it? And that's how you really sort of narrow the disparity gap between different communities. And we know that there's a big disparity amongst communities in the Massachusetts area, but these guys have done fantastic with the program on really sort of leveling the playing field for everybody. Because if you get everyone access, then really the cure rates are almost equivalent between different groups.
And one more question for you, Dr. Watson, before we go to the advocacy part. As women, we have our own routine mammograms that we're often reminded. How routine is prostate screening when it comes to healthcare?
I would say that it's in the guidelines to at least have that discussion. So I would say colon cancer screening, prostate cancer screening, testicular cancer. These are affect men at different age groups, and so we certainly do recommend there's these sort of U.S. preventative task force, and they give all the screening for all the different cancers A, B, C, or D rating. At one point prostate cancer was considered a D rating, and I would say that that's moved from a D rating to a C rating. Then certainly we are doing more, and I would say that from a population standpoint, you have a lot of studies that say, okay, well, I need to screen 1,000 men, treat 200 men to save one life. But if you're that guy who screening has saved your life, who cares what other people did? And so that's the problem with kind of using population-based statistics when we're looking at patients in front of us as individuals.
Thank you. And I see Dr. Kenan McKenzie has joined us. Kenan, want to take over?
Not necessarily, because I think you're doing a fabulous job as our health chair. I want everybody to give Mercy a huge round of virtual applause. Thank you so much. I had double duty with a conference at my college today, and so I knew it was in good hands. And thank you so much, Dr. Watson, for coming. Our doctor who has done this in previous years could not make it tonight. So I want to thank the AdMeTech team for coming and representing her and being able to share that with us. I'm going to have Thomas just cue us up with that, but I really was enjoying the Q&A and the robust conversation. So thank you all for your really good questions. And I know as a branch, we want to make sure we can do something to be encouraging and to advocate for access and education. And so I really appreciate your questions on that. Those are really important. So Thomas, I want to make sure you have an opportunity to share. The video is going to be approximately about 15 minutes. And like I said, there are some testimonials that I believe he wants to share in that. So I'll have you take it from here, Thomas.
Again, Dr. Stern apologizes for not being here. This kind of can answer a lot of different questions that you might have in regarding what AdMeTech does and everything else.
I'm Couillard, and I'm managing the Prostate Cancer Equity Program at AdMeTech Foundation. My thanks to the North Shore NAACP for the great partnership in creating this prostate cancer awareness event. Dr. Sean Wason reviewed exciting recent advances in patient care. Dr. Faina Stern and I will describe our Prostate Cancer Equity Program, which was created to bring these cutting-edge advances in screening, diagnosis, and treatment to Massachusetts men and eliminate health disparities. Dr. Stern is a physician and president of the AdMeTech Foundation, a nonprofit organization leading regional, national, and global programs in prostate cancer education, research, public awareness, advocacy, and clinical care equity. While Dr. Stern could not join us today due to a family emergency, she provided a video of her presentation. Prostate Cancer Equity Program is an integral part of the AdMeTech's ongoing statewide program in prostate cancer that created a Massachusetts model of national leadership in public awareness, medical education and research, and clinical care equity. We are grateful to the North Shore delegation to the State House who made this program possible. Our primary focus is on high-risk men, Black, Hispanic, and Latino individuals, and all men with family history of prostate cancer and increasing age, 50 and older. The prostate cancer program was initiated since 2009 in collaboration with multiple organizations and has 4 components: public awareness and community education, prostate cancer equity and clinical care, medical education, and research. Dr. Stern will now describe our program in more detail.
Our public awareness campaign, community education and outreach, is focused on the most vulnerable and underserved individuals. Since January 2023, we reached over 15,000 underprivileged individuals. This is a 50% increase compared to what we reported last year. Since 2019, our public awareness and education program reached over 52,000 people. For public awareness and education, our messaging is centered on the importance of screening and early detection critical for saving lives. Early detection is particularly important for Black, including Hispanic men, who are 2.5 times more likely to die compared to white men. With early detection of prostate cancer, every man is alive in 5 years. In sharp contrast, with late diagnosis, when cancer is spread to other organs, only 28% of men remain alive at the same time. The center of our medical education is AdMeTech's annual Global Summit on Precision Diagnosis and Treatment of Prostate Cancer. The latest 7th annual conference took place in September last year. Our summit has been recognized as a seminal event in shaping the state of the art and future vision for patient care. Our summit brings together the key international experts representing every clinical expertise to review the best emerging clinical practices and research priorities. Last September, we had over 300 physicians participating during this event. After the event, our media partners published over 60 scientific presentations and reached over 35,000 physicians across the globe. It's difficult to find any corner of the world that has not been reached by this event. Our summit showed that equal access to high quality care is the key factor in improving patient outcomes for all men and eliminating health disparities in Black men. It is particularly important now with so many novel diagnostics and therapeutic approaches, ensuring high quality, personalized, precision patient care. Without equal access to these advances in patient care, we will see a widening gap in health inequalities, including survival and mortality. Consequently, AdMeTech launched the Prostate Cancer Equity Program in Massachusetts in collaboration with Mass General Brigham, UMass, and other clinical institutions, with the mission to save lives and deliver high-quality care to all. Supporting organizations include Latino Health Insurance Program and multiple NAACP branches located across the state. Any Massachusetts man age 40 and older can participate. Our priority focus is on Black, Hispanic, and Latino men who are at higher risk of prostate cancer, delayed diagnosis, poor quality care, and death. Our goal is to expedite access to leading experts who use the most advanced approaches to screening, diagnosis, and treatment available today, and to support men every step of their medical journey. This program helps men to find an expert for the initial or a second opinion, in-person or virtual visits. We strongly believe that our prostate cancer equity program, integrated with our large-scale public awareness campaign, has been placing Massachusetts in a strong position to become the first state in our country to eliminate health disparities. Experts of the Prostate Cancer Equity Program can address any questions about prostate health, from assessing an individual healthy man's personal risk of cancer, to informing men about all available options before and after screening, biopsies, and treatment. We are committed to supporting men during every step of their medical journey to ensure that no man is left behind or struggling alone. To achieve this goal, we created a streamlined VIP-style process of patient referral and care, reflecting how doctors involved in this program take care of their families and friends. This process consists of three components. One, AdMeTech Foundation's team members collect basic information and match individual patients' needs with the appropriate state's experts for clinical care. Two, a clinical organization designates a patient navigator to expedite a medical visit and related needs, including scheduling, registration, transportation, any insurance, and financial assistance if needed. Three, if an expert recommends any next steps, AdMeTech's team and patient navigator work with men on the appropriate follow-up, such as testing or treatment. I'd like to share with you a few recent examples of how Prostate Cancer Equity Program has been making a difference. This is a case of a Black man with a history of prostate cancer who is currently being treated. On May 15, his doctor informed him that his scheduled treatment could not be provided due to problems with the insurance coverage. He got upset and shared his situation with a leader of the Men of Color Health Awareness Program, MOCA, our community partner in Springfield. On late afternoon of Friday, right before the Memorial Weekend, he contacted us and appealed for help. Our primary goal was to restore his treatment as soon as possible. And we immediately reached out to Dr. Mitchell Sokolov and his team at UMass and secured their support. On May 30th, right after Memorial Day, UMass Urology provided guidance to this man how to address his insurance issues. By Friday the same week, on June 2nd, the insurance issue had been resolved, and the appointment with Dr. Sokolov was scheduled at the earliest opportunity in early July to resume his treatment. The following Monday, MOCA leader heard what happened and asked for a second opinion for his own urologic health issue and received an appointment with a leading urologic expert within a few days of his request. This is a story of a Black man in his mid-50s who was referred to us about several months ago in mid-May by Cambridge NAACP. This man was recently diagnosed with prostate cancer. He got alarmed when his urologist informed him that the best care will not be available to him due to his limited insurance. We connected him right away with the patient navigator at the Mass General Brigham. She obtained a referral from his primary care physician and secured approval from his insurance. By June 6, this man saw Dr. Adam Feldman, a leading clinical expert and one of our featured physicians. Dr. Feldman described various treatment options but recommended surgery, which was performed in mid-August. We asked a few men to share how Prostate Cancer Equity Program has been making a difference for them. The first video was provided by Jose Javier of Lawrence, Massachusetts.
Hello, everyone. My name is Jose Javier. First, let me begin by thanking Dr. Stern for inviting me here today and being part of this. I'm excited to share with you and grateful to be able to share with you for a few minutes a little bit about my story and my experience with AdMeTech in the organization. I met Dr. Stern around the fall of 2015. I heard about her from a friend of mine at church, Victor McCann, which I'm grateful for because he was going through the same thing. And he was able to share at church, and I heard his testimony, and I was able to approach him after the service, and we had a great conversation. I was very shy about this subject. I too had a very high count of my PSA exam and had to go in for a biopsy. And I learned from Victor McCain the difference between an MRI biopsy, a guided biopsy, and also what is referred to as a blind biopsy. And those made a difference in my life. And I was able to meet Dr. Stern through this process. And I was able to go and get a MRI guided biopsy at the NIH and so forth. And it was a fantastic experience for me. So for me, part of the takeaway when it comes to this is really to be aware. Be aware, learn about the processes, learn what's available out there, what programs are available for you, what are the best tools to do the job. A very important thing is to share it. That's what I learned from my friend Victor, is to share it at church, share it with other people so they can learn as well. And because in our community, especially in the Black American community and the Latino community, it's a subject that is not often spoke about. When we talk about our private parts and speaking about the prostate, it's not always a conversation that is too welcoming in our community. So I would encourage people to share it, to learn. And as Governor Baker always says, get tested. You know, it's easy to get tested. Ask your doctor for a test and be aware and that there are solutions out there. We have great referrals, we have great doctors, and contact the leadership, the people at AdMeTech, and they're able to guide you in the right direction. Thank you. Please allow me to say a few words in Spanish. Para nuestra comunidad en español, este tema de cáncer en la próstata es un tema súper serio, muy serio, y es un tema que nos impacta a nuestra comunidad significantemente. Yo le quería decir a ustedes que, por favor, hablen con su médico si sienten algún síntoma, si están teniendo problemas orinando, cualquier irregularidades. Hablen con su médico, no tengan miedo de conversar con su médico, hablen con personas que tienen experiencias similares y eso le puede salvar su vida. Lo más importante es hacerse un examen PSA. Por favor, estudienlo bien y aprendan más. Gracias.
The second video features Ronald Roberts, who was referred to us by Martha's Vineyard NAACP.
Hi, everyone. I'm so glad to be here. My name is Ronald Roberts, and I'm just so glad to be included in this presentation. I have known about AdMeTech, and I met Dr. Stern years ago, and I would have never thought that I would be needing them so much last August when I was diagnosed on July 4th with prostate cancer that had spread to about 3 organs and lymph nodes, and I was in really bad shape. I ended up talking to Dr. Stern later on, and she directed me in the right direction. I ended up at Dana-Farber and jumping around to Brigham and Women's. I'm just fortunate, I consider myself fortunate to live in Massachusetts, where the medical help is available. If you know where to go, it really paid off for me. I'm doing pretty well after going through the MRIs and using the advanced equipment was provided to me. But through the direction of AdMeTech, I got to the right places. It takes a lot of willpower and positive thinking to do and go through what I did. I ended up driving over 3,600 miles, and that was after I had a driver that used to take me when I was weak. When you add the radiation, chemo in, 34 more appointments, it comes out to a lot of appointments, and I made every one. It was nice to know there was always somebody in the background that could help out if I had, I needed an opinion, and that was AdMeTech. And to bring people like myself that are patients, been exposed to the cancer, and survivors and people from the medical field and politicians. It's something that's badly needed for the minority community. We have the knowledge there. Things have changed a lot in terms of prostate cancer for the better. I'm taking a drug that's only 3 years old that has excellent results, but you got to know where it is and you got to be guided in the right direction. It's kind of frustrating that there's so many people out there that do have it and are not getting the help or not getting the proper help. I had put it off for years. I knew back in 2010 when I had Lyme disease, relapsing polychondritis, and babesiosis, and I forgot what else, all at the same time. I tried to treat the cancer back then with chemo, and it just got worse. So I just put it on the back burner. And I didn't even feel anything up until the few months before I was diagnosed, and that was I couldn't hold food down too well. Fortunately, a lot has changed since 2010, 11, when I was treated. There's a lot out there, a lot of new advanced machinery that can help with MRIs and radiation. We're fortunate in Massachusetts to have it available, and especially the Boston area. Without AdMeTech to guide you and be a resource, it's just so crucial if you need it, because sometimes you got to make a decision as to what the treatment is, and everybody's different. The reason I waited so long is trust, and that's a big thing. I have met other patients that have had mistakes or things didn't go right, and finally they got the right help, and waiting and insurance problems. And that's something that could be avoided or hopefully streamlined. And that's what AdMeTech is there for, if you catch it early. And it is so important to get tested early and continue the testing. The primary doctors should know more about AdMeTech. And one other thing, with the testing that I did do and all that I went through, what helped me, if nothing else, but mentally, was getting a DNA test. My father had passed from prostate cancer at about age 84. So I always thought it was hereditary. And through the DNA testing, I found it wasn't. But I do have the gene that causes colon cancer. And around December, I got a notice from, I think it was Dana-Farber, that that gene could possibly cause prostate cancer. And DNA testing also helps for alternative treatments. So it's good to do. And it helps my nephew and all know that they got to get tested and what to look for. The good thing about all this is there's a lot of research and things are changing fast. So even if you are sick, if you can hold in there, there's more on the way that could possibly help. And once again, what I did this past year, I couldn't do back in 2011. It wasn't available. And the idea of research and studies, and you do get a lot of notices for that, probably scares people too, because we think back to the Tuskegee study. I'm probably going to benefit from one of the studies they're going to do on me, and that is exercise in relation to the hormone therapy, the heart. So I'm looking forward to that in June. It's quite a study, quite a bit of exercise. I'm going to end it there.
As mentioned, I serve as a manager of the Prostate Cancer Equity Program. I am working closely with other members of our team, including Erin Roberts, the program coordinator, and Craig McClay, patient educator. When you come to us, I will work with you, our team, Mass General Brigham, UMass, and other clinical partners to expedite medical visits and address any needs you may have. Our team may not be able to right every social wrong that cannot be resolved by federal or state government, or provide perfect solutions for every man. And yet, we are committed to doing our best and making sure men are not left behind or struggling alone. If you have any questions about our program, need assistance, or would like more information, please contact me by phone 617-523-3535 or by email coordinator@admetechfoundation.org. Thank you for your attention.
That was terrific. Thank you so much, Emma, Thomas, and Craig. Thomas, I don't know if you all are in a position to do a Q&A for the video or to clarify anything, but I know Craig is here too. Does anybody have any comments or feedback or questions with regard to anything that you just saw?
I just want to say it was so touching. And I think the work you're doing is incredible. In our dysfunctional healthcare system, I think every one of us could benefit from having a navigator sometimes. But I think that, you know, anyone who's really disadvantaged in any way for any reason, difficulty with access or insurance or whatever, just needs that navigator times 10. The navigator makes all the difference. So I just think what you're doing is amazing. And for all the men on this Zoom tonight, I'll say those annual mammograms don't feel so good either. But look at that slide that shows 100%, 28%. If that doesn't convince you, prevention's key.
I agree with you, Nancy. Amazing work that AdMeTech is doing, really amazing in closing that gap on health disparities. So I guess our job is to spread the word on the work you're doing.
It is to spread the word. And as I would say, because I know we are very always concerned about where can we advocate. And I was happy to write a letter to Senator Lovely on behalf of AdMeTech last week to encourage full funding of their programming. I will encourage you all to reach out to your local representatives as well. So please do that. I know this is being streamed, so there may be people who are not physically being seen on the call, but it is important. I know we have a lot of budget challenges in the state, but these kinds of programs are essential for life and death for many communities. And the differential in the funding may seem small in the budget, but make a big difference to AdMeTech. So we are really hoping that we can make up that budget shortfall.
Thank you. I just got to say that on behalf of the AdMeTech team. Thank you. Our advocacy effort isn't done. We're going to have to go to the conference committee. So we'll be asking for your help in all the branches that we talk to and work with as well. That difference does make a difference. It's, as we talk about our PCE program, a lot of our funding does come from the state. So, and the advocacy work that we do and the community events and everything else all ties in together. So again, we're very grateful for not only supporters and not only in the legislature, but our community partners as well. We're all working together to get this disparity resolved as best we can. I think that is very important. So just again, thank you.
Well, with that, I want to thank the rest of your team that's here tonight. I want to thank our health committee for taking up the charge and spreading the word. They have had a busy week. They've also done a book discussion this week to look at racism in healthcare. And I know they're going to continue to take up the charge to make sure that this kind of information gets in front of our community. So thank you for arming them with even more information and resources and a new partner and connection in their work. I want to shout out our health committee chair. I want to thank our other health committee members who are here, including Nancy, and just our branch members and leadership for getting this call going tonight and making sure that our community was able to get this presentation. And of course, thank you, Dr. Mason. And I know that, I'm sorry that our other partners couldn't all be here in person, but we want to extend our thank you to her as well. So thanks, everyone.
Thank you for having us.
Thank you.
Thank you all.
Have a great night, everyone.
Great
night,
program.
everyone.
Thank you, everyone.